Hi there, my name is Dr. Brent McCauley, and this is Restoring the Knee, how to avoid surgery and get your life back. So, how many folks have difficulty walking up or down the stairs? How many of you have difficulty going down your driveway? The pitch of your driveway causes you knee pain, or you have to sit down when you're walking, can't bend down to pick something up, certainly can't bend at the knee, you end up having to bend at the back. These are all problems that folks are facing these days. And how many of you have been told that you're bone on bone? Well, I'm gonna refute that, and I hope you stick around, and I hope you learn something because this is a really great presentation, and our goal is to keep people off of the surgeon's table and getting them back to the parks, back to playing with grandchildren, going on vacations, riding bicycles, simply walking up and down stairs without having to take a break, playing golf again. We want good things for you, and we deliver. So sit back. I hope you enjoy. So the knee is what's called a synovial joint. It's a hinge. It's just a straight hinge that permits movement in one direction, just like the hinge on a door. All right. Your fingers, toes, elbows, and knees. So let's look at the anatomy of the knee. You have your thigh, your shin, and a little bone called your fibula off to the side, and your patella, your kneecap. So femur, tibia, patella, and fibula. You also have four ligaments: ACL, PCL, LCL, MCL. So four ligaments in there holding the bones together. And that's all there's, that's the only reason those ligaments are there. They are simply holding the bones together. They don't contribute to movement, and they don't really contribute to stability a whole lot. That's the job of the muscles and the tendons. Then you have the meniscus. The meniscus is a disc on either side of the knee. It's at the top of your shin bone. And if you see on this one, the area, see that you have the fibula, the little bone on the outside, that's on the outside next to your shin. And that outside part of the meniscus, that's where the damage is. That's the most common. It's the lateral or the outside part of the meniscus. That's the most common area of injury, especially when folks get older and they get, quote, bad knees. Why? Well, if you notice people who have bad knees, their knees kind of come together, they become knock-kneed. So when they become knock-kneed, that outside part gets squished. And when it gets squished, there's more friction and it wears out faster. We also have the muscles for extension, straightening the leg. All right, there are four of them that make up the quadriceps. Quadricep, quad, four. These are the four muscles involved in straightening your leg. All right, they all attach to your kneecap, and then you have a ligament that goes from the kneecap to your shin bone. All right, and then you have the muscles for flexing, bending the knee. All right, they're your hamstrings. There are three muscles involved in that. All right, and these attach to either side of the back of the knee. You see that there's some complicated things going on. On the left, you have the knee from the front, and on the right, you have the knee from the back. So, but there's one part of this anatomy that I'm fairly certain none of you have ever heard of. But first, I have a question for all of you. When you injure a bone, what tells your brain and lets it know that there's an injury? Where does that pain signal come from? The answer is a material called periosteum. All right. The periosteum is a dense fibrous membrane that covers the surface of all of your bones. It has the blood vessels, delivers oxygen and nutrients, and the periosteum holds the nerve fibers that transmit pain signals to the brain. Okay. Now, so you can see this in your mind's eye, if you've ever eaten ribs that are a little overdone, when you take a bite off of the rib and and you get the meat off, there's a thin, milky white membrane that might peel off of the bone itself. That's the periosteum. All right. That is what holds all of the nerves. All right. Now, the big reveal. Here's the dirty little secret. Periosteum covers the surface of the bones except those capped with cartilage, as in the joints and the site of the attachment of ligaments and tendons. So, and this is from the Encyclopedia Britannica, a resource that everybody knows, everybody can identify with. I didn't choose Dorland's Medical Dictionary or something else that 99% of the population couldn't identify with. This is in Britannica. So, what are the ends of your femur and your tibia, your thigh and your shin bone? What are those covered in? Those are covered in cartilage. So if the periosteum covers the surface of all bones except the end, which is covered by cartilage, how can bone on bone cause pain? You've been told that bone on bone is causing your pain, but how can that be? How can that be if the periosteum isn't there? You may be bone on bone, but even if you are, there isn't a membrane on the end of your bone to send a pain signal to your brain, right? So where's the pain coming from? Oh, and here's the diagram for you. You can see where the periosteum is and you can see where it stops. The periosteum is not on the green end where you have the articular cartilage. It is not there. Here are the 4 stages of degeneration. Phase 1, 2, and 3, there is still space there. There is still space in that joint. But yet, orthopedists will tell you that you're bone on bone and that's what's causing your pain. I beg to differ. Stage 4 looks to me to be bone on bone. And stage 4 accounts for 4% of the population. So what is happening with stage 3, 2, and 1 to constitute a knee replacement? It's very interesting, especially when we know that people have knees that hurt, but the substance that transmits the pain signal, the periosteum, is not covering the end of the bone. That joint space, there's no periosteum in there. None. So where's the pain coming from? We'll get there in a moment. Big business, knee replacements. $35,000 to $65,000 per knee. You have 2 of them. That's depending on whether or not there are complications. Most insurances will cover 80% of the cost. So if you are fortunate enough that you had no complications and it's $35,000 for that one knee replacement, you're going to be responsible for $7,000 of it. That doesn't include time off of work. That doesn't include the copay for all of the physical therapy you're going to require afterwards. That doesn't include gas, transportation. So you're looking at well over $10,000 per knee minimum. But 1 in 4 people, 25%, are going to need a second knee replacement. And that's not right knee, then you need the left. It's that the left knee will have to be replaced a second time. So the knee you had wore out in 65 years, but this hunk of titanium and plastic is going to wear out in less than 10 years. How is that possible? What are people doing? I don't think that people that are getting knees replaced over the age of 65 are going out and playing tackle football. They're not doing high impact things that are going to constitute wearing this knee out. The most common reason for a second knee replacement on the same knee is actually chronic pain, which 1 in 5 people report chronic post-operative pain. Well, last I checked, the reason for the knee replacement to begin with was the fact that your knee hurt and it was limiting your mobility because of the pain. Now, here's just a small fraction of the research that I've read. Knee surgery does not improve life quality in many patients. This is from the British Medical Journal. That's an incredibly reputable journal. My personal favorite, steroid injections increase cartilage loss in knee arthritis. That's from the Journal of the American Medical Association since 2017. Now these studies have been done since the 90s. Everyone knows that what steroids do. They're really great at decreasing inflammation, but what are they superb at doing? Steroids, when injected into the joint, will dissolve the cartilage, demineralize and weaken the bone, and weaken tendons and ligaments. So when an orthopedist says you're not ready for a knee replacement, but we'll give you a cortisone shot in the meantime until you're there, well, if that isn't a self-serving prophecy, they know that they're injecting this in and destroying the joint that you came in to get help on, but nobody tells you that, or at least not many folks do. Knee and hip steroid injections may speed joint damage in some patients. It's not some patients, it just does. But chondroitin sulfate helps knee osteoarthritis. Why? Because it helps to regrow cartilage. Interesting. So it helps create a cushion. It doesn't do much for knee pain, but it does prevent the arthritis from progressing. And again, this is just a small sample of the literature that I've read over the years, but we have a real problem when it comes to the knee in this country. So to review, the periosteum, the dense fibrous membrane that covers the surface of the bones that holds all of the nerve fibers that transmit the pain signal to the brain, covers all the surfaces of the bone except those capped with cartilage, which is the synovial joint known as the knee specifically. So if bone on bone isn't causing your pain, what is? The tendons. The tendons cause the pain. What people have is called a tendinopathy. All right. The tendons become inflamed because the knee is unstable. All right. The knee starts to move in directions it's not designed to. Remember, it's a hinge. It only moves one way. There shouldn't be any play in that joint. But as people get older and we walk in straight lines, because we walk linearly, the joint begins to move in ways it shouldn't, and that causes pain. So the muscles become weak, the ligaments have to pick up the slack, which is a job they're not designed to do. The knee becomes unstable. The brain tells the tendons that attach to the muscles, it tells the tendons to shorten, to stabilize. Now the cartilage in the meniscus wear out 6 to 10 times faster, and the fluid fills up the knee, causing more pain and swelling. All right, we call that a self-casting mechanism. How about, can the pelvis drive the instability? You bet. This is one of my patients. This patient has chronic knee pain. Is that surprising? No? Which knee do you think is going to wear out first on this patient? Look at this. Look at those bone spurs on the front. Look at the lack of disc space there. Do you think this patient might walk differently to avoid pain in their back? And now, because their gait when they walk is thrown off, now their knees are starting to degenerate? Absolutely. The proof is in the limitations, folks. Squatting to the floor becomes difficult, if not impossible. The pitch of the driveway, especially downhill, becomes painful. Stairs, especially going down, hurts. All right, limited flexibility in the muscles. Why? Why limited flexibility? Because the tendons have to shorten in order to stabilize the joint. So since the tendons have to shorten, they're tight, and now you lose flexibility. All right? You can't touch your toes or bring your heel up to your buttocks. This is a great test. You should absolutely be able to do that. If you can't, it's very likely you have a tendinopathy. It's very likely those tendons are trying to stabilize your joint for you. So what's our process? First, the analysis and examination of 4 things. We're going to look at your muscle strength and flexibility. We're going to look to see if your ligaments are stable. We're going to do bilateral weight measurement to see if you are favoring one side or the other. That's a very good indicator that something is happening either in your pelvis or your spine. And we're going to take digital x-rays of your knee and pelvis. Why? Because I want to see what your pelvis looks like, and I want to prove that you are very likely not bone on bone. So the innate life formula for saving your knees and getting you back out there and living your life is we're going to turn off the tendinopathy. All right. This is going to decrease the pain in your knee, which is going to increase the mobility. Now that you have increased mobility, you're going to decrease the swelling because your ability to move is going to pump the fluid out of your knee. Now that that happens, you move easier, you have less pain, and now we can strengthen the muscles around your knee and stabilize those joints. How do we do that? We use this device. It's called the NeonTrack. This is mechanical knee decompression. This is state-of-the-art, cutting edge. It is being used all over the country, and people are getting spectacular results from this alone. But our protocol has even more. Here's an example of how this is used. Strap your leg down, engage the machine, and it gently pulls your leg away from the body. This is going to rehydrate the material inside of the knee, and it helps to deactivate the tendinopathy. The gentle pumping action means that nothing is abrupt, nothing is fast. We take our time, slow and steady, and we get spectacular results. What else do we use? We use the Rebuilder. This is FDA approved to stop the pain transmission signal. Why? Because the tendinopathy is what causes the pain, and that's what's keeping you from moving and doing certain very specific isolated exercises. If we can turn that pain signal off to the brain, we've opened a window of opportunity for you to strengthen the muscles and start moving forward with your life. Another thing we have is a vibration platform. This is by Pettibon. This is going to help improve your balance, increase circulation, which is going to speed up healing, increase your bone density, and improve the muscle recovery. These are all unique parts to our protocol, helping us get not only exceptional results, but accelerated, faster results. So what's the takeaway? Pain comes from the tendons, and that's a result of instability. All right. X-rays will determine if the pelvis is driving that instability. The Rebuilder turns off the tendinopathy. The NeonTrack decompresses the meniscus. The vibration stimulates the nerves in the brain to accelerate healing. Target specific exercises to create stability around the knee, and you get your life back without surgery.